And then we are excited to be continuing our genetic series. So today we're going to be learning about the NPM1 mutation in AML. As NPM1 is a pretty common mutation within AML, we're excited to be able to bring all of this information to you. If you missed the first two webinars in this series, I'll share the info for those at the end so you can get caught up. But first, I'd like to introduce our speaker today, Dr. Shai Shimony. Dr. Shimony is a leukemia specialist with advanced training from Dana-Farber Cancer Institute and has a master's in clinical effectiveness from Harvard. His clinical and research focus centers around improving care and outcomes for patients with acute leukemias, especially AML, ALL, and rare subtypes like BPDCN. I am so excited to have him here with us today to present. So with that, I'm going to go ahead and turn the time over to him.
Thank you, Mary, very much. You see, do you see my screen well?
Yes.
Great. So thank you very much, everybody, for joining today. I am Shai, as Mary said, from Dana-Farber, and it is a real pleasure and a great privilege to be here today with you. And I would like to thank HealthTree for the opportunity to discuss about the exciting topic of NPM1 ALL, and our title today is Demystifying NPM1 in AML. What does it mean and why it matters? Our themes for today would be overview of what is acute myeloid leukemia. Just for all of us to have a general base for our talk today. I won't dive into it too much. Then we'll talk a bit about what is MRD, or measurable residual disease. You may have heard about it in a previous conversation, but it is very important in NPM1, so I'll just briefly touch on that. Then we'll dive into what is NPM1 or nucleofusamin 1. How do we harness the data that we have with NPM1 for the management of AML? And I'll touch on at the end of the NPM1 session about targeted therapies that we have today for NPM1. And the most important part, in my opinion, is the discussion with you and answering your questions. I have no disclosures, and let us start. An overview of AML and integration of molecular data. So, as you know, AML is a rare disease. It's about 1% of adult cancers, and we have in the United States about 20,000 cases a year. The median age of AML is 69, and the symptoms of presentations, as you know, are not very specific. It's general malaise, some fever, weight loss, not feeling well, maybe some bruising, and then a person goes to the doctor, and then they send blood test, and the labs seems abnormal. Now, to understand how does AML or any type of cancer evolve, you need to understand how we as specialists see or visualize the word cancer. Cancer for me just means a cells that divides abnormally, and whether it's in the bone marrow, then it will be a blood cancer, or in the lung, then it will be lung cancer. It's just a cell that lost its normal function and just divide more and more. This is cancer. And in terms of leukemia or AML, acute myeloid leukemia, we're talking about a cell in the bone marrow that divide and proliferate without any control. So the normal cells, as you see here on the top, do you see my marker over here?
Yes.
Great. So the normal cell here, this is the hematopoietic stem cell that we all have in our bone marrow. Bone marrow is the factory where all blood cells are manufactured, and it goes to and it produces one of three lines of or cell lines that we have in our body. The erythrocyte, or what we usually call hemoglobin. If they're low, we're weak. The platelets, if they're low, we have a tendency to bleed. And all of these together are white blood cells. And their normal function is to protect us from infections. And now let's talk a bit about that hematopoietic stem cell. And the way I present it usually to my patients is I compare it to something more familiar, which is a library. Okay, this is the Boston Public Library that we have here in Boston. So envision that the hematopoietic stem cell is the Boston Library. Okay, within the library that is here, we have bookshelves. These bookshelves are the chromosomes or all that condensed DNA that we have inside the cell. Each chromosome contains a lot of genes, like every shelf contains a lot of books, and they are organized within these chromosomes. And within each book, we have a lot of letters that write to us the recipes for baking a cake or reading an interesting story. And the same way the DNA generate the genes that tell our body how to function. What happens in AML is that one of these books, one of the pages is rotten or torn, and then we have mutations. The DNA changes and the books are no longer reading for the cake that we love, and the proteins are no longer functioning. And at the end of the day, the entire library is not functioning well, and the cell lose the control and just start to proliferate. This is how cancer evolved, and in the case of leukemia, this is how acute myeloid leukemia evolved from that hematopoietic stem cell. Now, these changes not necessarily evolve into acute myeloid leukemia, and we acquire all of these changes, these mutations, these torn pages in books with time. And as we age, we get more and more of these changes until in the minority of people, these changes can, accumulation of these changes can occur in the formation of acute myeloid leukemia. Now, why do I tell you all of these uh, um, stories about genes and torn books? It's because these pages or these books, the mutations are actually what causes the leukemia. And if you can see here, this is a seminal work from 2016 that shows the mutational panel in over 3,000 patients with AML. You can see that the most common mutation is FLT3 in this cohort, and the second most common mutation here is NPM1. And this is important because this will allow us both to evaluate how severe the disease is, and also it allows us to look for targetable mutations that we can target with therapies. And from this work by Greenway 2016 as well, you can see that a third of the patients with AML harbor an NPM1 mutation. And I would say that NPM1 in younger patients is probably the most common mutation, and it lowers a bit with age, but it is still a very common mutation that we see with AML. And before we continue, I want to tell you a bit how we evaluate AML. So if a patient comes to the clinic and I want to say, I want to evaluate whether or not he has AML, I do the bone marrow biopsy. And what do I get from the bone marrow biopsy? The first thing is I look under the microscope and look on the library. And this is called in our language morphology, how the cell looks. Then the next thing, I look on a test that's called immunophenotype, and that marks all the windows that we can see outside. And it matters because A, they can be a target for therapy, and B, they tell us about the severity of the disease or the subtype of the disease. Then we look on the bookshelves. As you remember, these are the chromosomes. and changes in chromosomes can also relate to um, um, a subdivision of AML. And finally, we sequence all our patients and we find out what are the mutations, what happened in the books, and which letters are inaccurate or incorrect that cause these mutations. And again, why does it important? Because if we know the mutations, we can classify and we can target therapies for AML. So if you look on that, you'll see that from 2017, we have 12 new drugs that were approved for AML, FDA approved for AML. Some of them are also approved in Europe. And you can see in blue, like midostaurin, enasidenib, gilteritinib, all the drugs here in blue are drugs that target specific mutations. So it's not just for the classification, it's if we know a specific mutation, this may be a targetable mutation that we can help our patient with. Okay. This was the first part, just an introduction. How do I envision AML? Why does mutation matter? And how common is NPM1 mutation? Now I want to discuss about a very important concept that's called measurable residual disease. The way we treat AML these days is the first step is trying to get what we call a remission, a complete remission, which means less than 5% of these leukemia cells, blasts, cancer cells in the bone marrow, and no cancer cells in the blood. This is based on historical studies that shows that less than 5% of these cells in the blood correlates with improved survival. However, now, as opposed to previous years, we have all kinds of techniques to measure much smaller amount of disease. And we have the evidence to show that these small amount of disease, if we can find them, they also correlate with survival. And furthermore, if we find these small amounts of disease or measurable residual disease, there are types of techniques that we can try to eliminate these small amounts of disease and then improve our patient's survival. There are several techniques to measure the measurable residual disease, or MRD. I would say the bigger two are the flow cytometry, and if I'll remind you what is flow, if we'll go back to our library, flow is that. So looking on the windows of the blasts of the library, that's one method to measure MRD. And the other method to measure MRD is either by PCR or DNA sequencing, both methods that target the books and the letters. So we can measure MRD or these small amounts of disease with that. We cannot see this disease by the microscope, but we can measure them with techniques that we have today. And if we look on this illustration, and here at the top, we can see a patient is being diagnosed and is being treated. So the burden of disease is going down, and this is the level that we call CR or complete remission, less than 5%. But if there is still measurable residual disease, this patient will relapse. If we treat him and eliminate more of the disease, we may gain some more time, but eventually, if there is a residual disease here, the patient will relapse. But our goal is to get to curve number 3, eliminate all the measurable residual disease, or as much as we can, to try and achieve a long-term remission and possibly cure. This is the concept of measurable residual disease. Why do I tell you all of that? Again, our goal is to improve survival. This is a big meta-analysis that showed, meta-analysis means a bunch of studies lumped together and with all kinds of mathematical methods, we are getting data on more people that shows that if patients who are in MRD negative state, they survived longer. They had better survival. Okay, this was measurable residual disease. And now we can dive for the main reason why we're here, nucleophosmin mutation or NPM1 mutation. So NPM1 codes for a shuttle protein that lives in the nucleus of the cell. And in 2005, Fellini and his colleagues showed that NPM1A is very common in AML, and B, that this is a crucial part in generating AML. And what happens is when NPM1 AML forms, here in red you see the nucleus of the cells, and the green is the NPM1, and the green is next to the nucleus of the cell. When NPM1 becomes mutated, he is getting out of the nucleus, so is out of the red area and dispersed in the cytoplasm of the cell. This is part of the pathophysiology of the cancer formation, of the acute myeloid leukemia formation. And this is the hallmark of mutated NPM1, where he gets out of the nucleus and go into the cytoplasm, and with a bunch of subsequent actions causes the leukemia. NPM1 in 2022, the mutated NPM1 by itself is an AML defining event, which means if a patient comes to us and have abnormal counts, and I find an NPM1 mutation, on the right you see the WHO criteria, which defines that irrespective if he has or doesn't have any blasts or bad cells, he is called only by that NPM1 acute myeloid leukemia. Another classification that you can see on the left by the International Consortium define NPM1 with 10% of blast, while the traditional definition of acute myeloid leukemia was 20% of blast. The definition by ICC is 10% with NPM1, and the definition by WHO, the World Health Organization, is if there is NPM1, this is acute myeloid leukemia, because we don't find mutated NPM1 in other diseases. How about the prognostic value of NPM1? So this is the ELN 2022 criteria, the risk criteria of AML, and we can see that patients who are classified or who have NPM1 mutations are classified as favorable prognosis AML. These classifications is for patients who are treated with the intensive chemotherapies, like 7 or the classical 7+3. Now, this classification, which came later on, this is the ELN 2024 classification. This is for patients who are treated with the lower intensive therapy or lesser intensive therapy, or now the standard of care for older patients is hypomethylating agents plus venetoclax. This shows that patients with NPM1 is also considered a favorable risk mutation, with a median overall survival in the phase 3 trial that you can see here about 40 months. Now, why did I tell you all of this story about MRD and measurable residual disease? And you can say, Shai, this was complicated. Why do you tell us all these? Why did you give us all this introduction? So this is the reason why. In 2016, Ivy and his colleagues showed that if if a person has an NPM1 negative disease or MRD negative disease measured by the NPM1, because NPM1 is easy to measure, this is a good indicator for his survival status. And what you can see on the left is that patients that were MRD negative in the black curve lived longer than patients who were MRD positive, and this is after their 2 cycles of chemotherapy. So the MRD measured by NPM1, which is rather easy to measure, is our poster boy for how do we integrate MRD into our analysis and into our management. NPM1 was also found as a poster boy for MRD marker, even in patients who go after transplant. This is a paper by Laura Dillon that published 2 years ago and showed that MRD measured NPM1, sorry, MRD measured by NPM1 is also predictive of survival after transplant. So it's not only among all patients in AML, it's even good for patients who are continuing with allogeneic stem cell transplant. So far, we talked about the prognostic value of NPM1, which means I have data from NPM1. What does it tell me about the longevity, about the survival? But does this data also can help us make or change our decisions? So Jed Othman and his colleagues last year showed that among patients who were treated with intensive chemotherapy, if they achieve MRD negative NPM1 after 2 cycles of chemotherapy, there is no need for transplant for these patients. So this is a good evidence for us to say, okay, I have a tool, now I can use it. I can make my decision based upon this MRD at the end of 2 cycles of intensive chemotherapy. And what about patients who are treated with hypomethylating agents and venetoclax, or azacitidine and venetoclax, or decitabine plus venetoclax, or as a group, what we call the lesser intensive chemotherapies? The same person, Jed, showed that it is also the MRD measured by NPM1 can also help us make decisions about patients who are treated with lesser intensive therapies. And what you can see on the left is that patients who are MRD negative lived longer, but also you can see here in the dark blue patients who were on therapy, but this is off therapy, which means patients who were MRD negative stopped therapy with lower intensive therapies and had prolonged survival even without therapies. And this revolutionized the idea that maybe patients with MRD negativity, we can stop this ongoing therapy and maybe they get to a certain point that is called cure, because the current dogma is that with hypomethylating agents and venetoclax is a great treatment for AML, but they are not curable and patients need to be treated ongoing. This is the first time that, or one of the first time that we can see that maybe patient can stop therapy if we just follow their MRD1, and maybe there is cure at the end of this tunnel. Now, the last part about the NPM1. NPM1 can also serve as a therapeutic target. So if you remember, I told you that the mutated NPM1 goes from the green inside the nucleus and goes out into the cytoplasm of the cell. There were some experiments that showed that if we can reverse this and get the NPM1 inside back into the nucleus, or stop the process that is caused by this shift of the NPM1, we may reverse leukemia. So revimenib is a drug that was evaluated and was approved in November of last year for a KMT2A rearranged relapsed refractory AML patients. But this drug does not only affect those with KMT2A AML, it also downregulates HOX-BOX expression. And if I'll go a slide back, you can see that the action that is derived through the NPM1 or NPM1 act for progressing the leukemia is through this HOX-BOX gene. So if we can stop that, we may be able to reverse the detrimental effects of mutated NPM1. And actually, just less than 2 months ago, the same group that presented the data about the KMT2A AML presented the data about NPM1 mutated AML and show high efficacy and safety of using this drug, revimenib, in NPM1 mutated AML. So this is another option that we have in our toolbox for patients who are NPM1 mutated AML. Now, revimenib is only one of 5, and there are more to come. And this is the one that is approved now, but my estimation that at least 1 or 2 will be approved in the near future. But we'll wait for the data to show that. But there is a lot of interest in the last ASH meeting, there was a whole session just about these menin inhibitors. They're a big excitement, and we're very happy to see their efficacy because, as I showed you, NPM1, a third of our patients have NPM1. And so it's very common, and we want a drug that we can use in a lot of patients. So we talked about a lot about what is NPM1, how do we use it to predict survival, how to use it to manage our patients, and how do we use it as a therapeutic agent. This is an algorithm that in a review, me and one of my colleagues wrote a while ago about how do we evaluate and treat patients with NPM1. And I won't go into all of the details, but the take-home message here is that the MRD evaluation with NPM1 is crucial in making our decision. And one may consider that it's always a shared discussion with the doctor and the patient and his family and the goals of care, but one may decide with his doctor that, okay, we achieved MRD negativity, I may try to pursue not going to transplant. Or after a year of getting HMA-VEN and with MRD negativity, and if a person has side effects, I have a patient with 2 years treated with an NPM1 mutated AML on an hypomethylating agent and venetoclax, and we had the discussion last time she was here about should we stop the treatment, should we not stop the treatment because her MRD is negative, and this is an ongoing discussion with her. And I also want to highlight the fact that NPM1 now is part of the management of relapse refractory AML. It is not yet FDA approved for that purpose, but me and some of my colleagues, and I know all across the state, are using this, and it's also part of trials that are now using menin inhibitors in NPM1 mutated AML. And with that, I would like to thank all of my colleagues here at Dana-Farber. And I think most of all, the biggest thank you is to you. It is a real honor, a real privilege to be part of this journey that you're taking, and it's really our honor to escort you along that. And that's it.
Thank you so much for this presentation and for really going over NPM1, the context of why it's important and what kinds of things we can do with the NPM1 gene. So now we want to open it up to questions and comments. So if you have a question you'd like to share or a comment you want to share, you can do that either verbally by using the raise your hand feature, or you can send your question in the chat. So we'd like to go ahead and open this up and make it available for you to ask your questions. Something that I was thinking about as you were presenting, and something that I know I've had people ask me, that's becoming more and more prevalent as we get more targeted options for patients. And a lot of patients have multiple mutations. So, say a patient has NPM1 and FLT3, are they able to use the targeted drugs for NPM1, and how does that kind of work?
That's a great question. Thanks, Mary. So we still don't have a great answer for that. I would say upfront therapy, menin inhibitors are not yet approved for the upfront therapy. So if a patient's come with an NPM1 and a FLT3 mutation, which is very common, about 50% of patients with NPM1 also harbor a FLT3 mutation. Um, we usually use we add the midostaurin or gilteritinib or quizartinib, which are FLT3 inhibitors that are approved for upfront therapy if we use intensive chemotherapy. There are ongoing trials, both in Alliance trial and MyeloMatch, which is a huge collaboration between a lot of institutes, that we tried to integrate both a menin inhibitor and a FLT3 inhibitor alongside with either intensive chemotherapy backbone or another backbone. So we are evaluating these combination now in trials, but for the upfront therapy, for now, we still use FLT3 inhibitor if a patient has these two commutations.
Thank you for answering that. I'm looking to see if we have any hands raised or any questions that people would like to ask. All right, Brian, would you like to ask your question?
Sure. Am I on there?
Yes.
Uh, just in a brief explanation. So, I was diagnosed in 2023 in August, did not go into remission. I had NP1M and IDH2. Uh, Went ahead eventually into remission on venetoclax and um, um,
Decitabine or
yeah,
azacitidine?
right. Went into remission with that. Went ahead and had a stem cell transplant in March of 2024. So I'm about 16 months post that. All of my bone marrow biopsies since then have shown no residual disease, and the mutations are undetectable. My last one was recently 100% donor across the board. So my question to you is, I know the measurements can only be calibrated so low, but I'm curious how relapse of disease happens within that. Where is the current research on where some of this might hide, or how it again gets um, gets going again, I guess is the easiest way to say it. So thanks.
So thanks, Brian. First, I'm very glad to hear that you're in deep remission after the transplant. I would say that the combination that you have of NPM1 IDH2 is the one that we recognize as a community that is the most responsive to decitabine and venetoclax or azacitidine and venetoclax, and with prolonged remissions. Now, about your question about how do we monitor and where do the disease hide, our ability today to locate the measurable residual disease is going low as 10 to the minus of 6. So one cell in a million, that's the way that's the most sophisticated ways that we can locate today. And there is good evidence to show that if we locate this MRD, there is likelihood for relapse of the disease. So we are working currently in our field to try to target the measurable residual disease before it evolves into something larger than that. I would say that in your specific case, there are two targetable mutations, both IDH2 and NPM1, that if in the future any sign of any residual disease will come up, both of them can be targetable. But for now, we just follow with measurement on these. But these are evaluated now in ongoing studies.
Yeah, and I'll add that I'm out of Portland, Oregon, so I'm out of OHSU. They've had me on. I can never say Incinerative well. The trade name is Hoffa, and
Yeah,
they have me on protocol for 2 years, so I'm well over a year into it for the IDH2. So they do have me on as part of a protocol.
That's a great group with great people, and I'm very happy for you for that.
Great. Thank you. And thank you for talking. Yeah, it's insightful to see. So thank you.
Another question I was thinking about as we talked, we know that sometimes mutations can change throughout a person's experience with AML. Sometimes you gain a mutation, sometimes you lose a mutation. How is that impacted by or how is someone's ability to receive treatment with a mutated, specific drug? How is that affected by that
That's
experience?
that's a great point, especially when we talk about NPM1, because NPM1 is what we call defining de novo mutations. So most patients with NPM1, it means that they didn't have a precursor disease like MDS or something like that. And NPM1 usually present at the beginning of the disease, not as a progression mutation or resistant mutation. Having said that, there are patients that can progress through other mutations. The most common one are RAS pathway mutations, RAS MAP kinase mutations, that's a whole other group of mutations that we know that are associated with progression and a more resistant disease. Currently, there is no drug approved for these mutations, but we are working on that. My colleague here in the room is actively working on that, and the sequencing of mutations matters, of course, but in our context, NPM1 is usually a mutation that presents in the start, and for us, symbolize this is what we call a de novo or a newly diagnosed de novo ontogeny AML, which means this patients with NPM1 usually don't have low counts for years and then develop AML. It's just one bright day, usually.
Thank you for explaining that. I think that's something that can get very confusing with the way that genetics and mutations work, especially in diseases that are already confusing, like AML. I'm not seeing any other questions or hands raised. So if we're good, and nobody else has any questions, then I just want to say thank you so much again for coming and for presenting, for being a part of this series of educational events, and for taking the time out of your day to prepare this presentation and to come and speak with us.
Of course, it's really a privilege and an honor, and I enjoy it every day of trying to help and improve this field. Thank you.
As we leave the session today, we would appreciate if you take that 2-minute survey to fill out that I mentioned at the beginning about your experience today, and also to share topics that you're interested in so that we can get those topics and webinars planned for you. I just wanted to mention a couple of things coming up. So on July 16th, we're going to have a webinar that's centered around helping to manage AML symptoms and taking care of emotional health. This is one we're really excited about, and I really hope to see you there. I also wanted to give a little bit of a first sneak peek at something that I've been planning all year that I'm really excited about. We're going to be hosting special virtual regional webinars for our AML community throughout the months of August and September. So, this is the first time we've done anything like this, and I have two main goals for these webinars. The first is to let you all hear from an expert that's from your specific region about practical information that you need after an AML diagnosis and to help you manage your disease throughout your treatment. And then the second goal is to bring you direct links to resources that are local to your area. So think things like other nonprofits, support services that have special offerings for cancer patients, resources, support groups, things like that. Things that we think will help you to have the support that you need and deserve during this time. So those will all be local to each region. And then at the end of the presentation and resource sharing, we're going to leave time open for you to be able to meet and connect with other patients and caregivers that are near you. So I'm really excited about these events. We're still solidifying a couple of the dates, but you're going to receive an email soon that has all of the links and you can register for your local one. If you have any thoughts about these events, resources you'd love to see included, my email is going to be on the last slide, and I would love for you to share them because we really want these events to be helpful and meaningful. So please share any thoughts or feedback that you have. And then lastly, if you missed the first two webinars in this genetic series, I'm going to include the links in the follow-up email to this event. So you'll have those links. You can get caught up. There's one that's a great overview of genetics and why genetic testing matters, and then a deep dive into the FLT3 mutation. Both are great resources. So those will be also linked in the email you're going to get after this webinar. Again, we're really grateful for the support of our AML sponsor, Cura Oncology, who makes educational events like these possible. And then I finally wanted to just say thank you to all of you for being a part of our AML community. Your support means so much, and we're so grateful to have you here. I have my email on the slide here, so please don't hesitate to reach out if you have any questions about HealthTree, our programs, or if you're interested in sharing your experience. I set aside time each week. Any day is available, but specifically I set aside time on Mondays and Wednesdays to meet with members of our AML community to get to know each other better, to hear your story, to help connect you to resources, or to hear thoughts on topics that you'd love to have us cover, just generally getting to know the people in our community. Meeting with everyone is truly my favorite part of my job, so please don't hesitate to reach out if you're interested in connecting. I would love to meet you. I really appreciate all of you, and I am so glad that you came to this webinar today. I hope you have a wonderful rest of your day and hope to see you on another webinar soon.